Good evening to all. Thank you, Sandeep sir, for this opportunity. So I'm going to discuss the biomarkers for efficacy for immunotherapy in advanced non-small cell lung cancer. These are the non-PDL1, non-MSI, and non-tumor mutation burden. Next. Okay. So when you look at the biomarkers for immune checkpoint inhibitors, we can divide them into three different groups. These are the markers of efficacy, markers of resistance, which is called as invalid response, and also markers for toxic response, which is a hyperprogressive disease. So we already had some amount of discussion regarding the efficacy markers. These are the PDL1, tumor mutation burden, and as well as MSI high histology. I'm going to concentrate on the rest of the major markers. Basically, these are the adjuvant markers that can be complementing the other PDL1, TMB, and MSI high histology. These are the tumor infiltrating lymphocytes, mutations in the genes that are responsible for the DNA damage repair, KRAS mutation, TP53 mutation. So we look at the markers of resistance or invalid response. These are the EGFR ALK mutations, MET exon 14 mutation, and also those genes which are involved in the interferon signaling. These are the JAK1, 2, SKT, STK11, LKB1, and PTEN loss. So look at the markers of toxic response or hyperprogressive disease. These are the MDM2/4 amplification, mutations in the EGFR gene, 11q13, and as well as cyclin-dependent kinase 2A and 2B. Again, deletions in the DNA methyltransferase 3A is also responsible for the hyperprogressive disease. Looking at the tumor infiltrating lymphocytes, there is enough clinical data to suggest that these are prognostic. We know that abundance of tumor infiltrating lymphocytes in the primary tissue can be prognostic in several solid tumors. We have a Chinese paper, which is a meta-analysis of all the clinical trials testing the tumor infiltrating lymphocytes in the lung cancer. And they have shown that it is not only the abundance of the T lymphocytes, but also the quality of the profile, whether it's a CD3 positive, CD8 positive, or CD4 helper cells, and their relative location in the tumor microenvironment, which is a tumor stroma, peristromal tissue, or in tumor nest, which is responsible for variable prognosis of tumor infiltrating lymphocytes. In general, the proliferation of CD8 positive T lymphocytes has been associated with the shrinkage of tumor on imaging after the immune checkpoint inhibition. And the proof of concept comes from the Keynote 001 clinical trial, wherein pembrolizumab, when used in the advanced metastatic non-small cell lung cancer, the number of CD8 positive T lymphocytes in the tumor parenchyma, as well as in the margins of the baseline biopsy specimen, was shown to be correlating with the response. Again, not only in the metastatic disease, but also in the non-metastatic disease, and not also with the immunotherapy, but also with the CTRT, the univariate and multivariate analysis has demonstrated that the CD8 positive T lymphocyte density could be an independent and significant predictor for both PFS and overall survival. Other mutations, these are the KRAS mutations. Nearly 20% of all the patients with non-small cell lung cancer patients can have these KRAS mutations. And the clinical phenotype include those with smoking history, as well as lung adenocarcinoma. And this KRAS mutation can be implicated as a primary driver mutation, as well as the secondary mutation that can result in tumor progression. However, KRAS mutation did not correlate or regulate the PDL1 expression, and available clinical data is variable regarding the correlation between the KRAS mutation as well as the PDL1 expression. We have the Checkmate 057 clinical trial data, which is a phase 3 randomized study testing the nivolumab versus docetaxel in the second-line setting in advanced non-small cell lung cancer. And we can see clearly that KRAS mutation patients benefited more from the nivolumab compared to those without the KRAS mutations. You can see the hazard ratio in those patients with the KRAS mutation is around 0.52. In those patients without detection of the KRAS or unreported KRAS, the hazard ratio was not statistically significant. Again, this is the BIP study, which is basically testing the atezolizumab in several lines of non-small cell lung cancer, advanced non-small cell lung cancer. Again, KRAS mutation patients receiving atezolizumab had a better outcome compared to that of the wild-type KRAS. Coming to the TP53 mutation, much more common mutation, this squamous cell carcinoma. Nearly 80% of this squamous cell carcinoma have this mutation. Nearly 2/3 of lung large cell adenocarcinomas in 50%. And we have an integrated analysis from the Dong et al. They have compiled the multidimensional data types, including the genomics, transcriptomics, and clinical data. And they have reported that the mutations of TP53 and KRAS increase the expression of PDL1 and infiltration of the CD8 positive T lymphocytes. And the same group has correlated that a co-mutation of both TP53 and KRAS manifested increased overall response rates and increased PFS. So coming to the genes and signaling pathways associated with the DNA damage repair, these are the genes that encode for several functional proteins which are part of the several DNA damage repair mechanisms, which include base excision repair, nucleotide excision repair, non-homologous and homologous excision repair, end joining repair, and TP53. Again, these mutations in these genes results in genomic instability, and it is correlated with the high levels of tumor mutation burden. And these mutations can really result in increasing in the non-synonymous mutations and increase the tumor infiltrating lymphocytes, and by theory can make the patients more sensitive to immunotherapy. Finally, I will try to conclude with predictors of toxic immunotherapy. Basically, hyperprogressive disease can also be known as toxic response. It can be expected that nearly 15% of the patients with non-small cell lung cancer, when treated with immunotherapy, can be expected to have this hyperprogressive disease. Clinical characteristics of advanced age, high tumor burden, and local recurrence has actually predicted for the hyperprogressive disease, but this is inconsistent at best. So there are several genomic signatures like MDM2/4 amplification, DNA methyltransferase 3 alpha mutation, and mutations in the EGFR and 11q have correlated with the hyperprogressive disease. So in conclusion, biomarkers can predict treatment responses. It can help formulate rational therapeutic combination and enhance the efficacy of immune checkpoint inhibition. And these incorporation of these biomarkers can result in decision-making algorithms and also nomograms or bioscore systems, which will help the clinicians to make a better choice during their clinical practice. With that note, I would like to thank the organizers for this opportunity. Thank you for patient listening. Thank you very much.
Thank you very much, Dr. Rakesh. Now all sessions of today's is completed and mic handed over to Program Director.